Hi, everybody. Welcome to the Managing Fear of Cancer Recurrence talk in our Your Life After Cancer virtual conference. We're just going to give it a couple minutes before we start and let a few other people join the Zoom chat. When you're in, go to the chat and let us know where you're joining us from so that we know where everybody is across Canada today. Vancouver, Newfoundland, more BC, Ottawa, Calgary, Winnipeg, more Vancouver, Nova Scotia, Ottawa. Wow, from everywhere. There's 62 people joined right now.
That's fantastic.
So we'll just give it another minute and then I'm going to get started, and so that we have enough time to hear everything. And from Hamilton, Ontario, Uxbridge, Ontario, just down the street from me, PEI. And then we have enough time to ask all of the questions that we want to ask. Okay, so I'm going to get started and we'll just let everybody join as we go. So welcome to the Your Life After Cancer conference. Throughout the week, you'll be treated to interactive presentations and expert approved tools and tips and recommendations to help you find your own path to fulfilling a life after blood cancer or with a chronic blood cancer. The Leukemia and Lymphoma Society of Canada is proud to introduce today's presentation titled Managing Fear of Cancer Recurrence. Experiencing a fear of cancer recurrence is very normal. Most cancer survivors will experience this fear. Living with this uncertainty is not easy. In this presentation, Dr. Christian Schulz-Quach, a staff psychiatrist at Princess Margaret Cancer Centre, will explain this feeling and its impact and share some strategies on how to manage it. Now I would like to introduce myself. My name is Leslie Ann Guiney, and if you're from the east side of Ontario, you probably already know me. And I am the community services lead for the east side of Ontario here at the LLSC, and I will be your moderator for this online event. Since there are so many of you here today, which we're really happy to have, I wanted to invite you to type your questions and comments into the question box or into the chat on your Zoom panel. And an LLSC staff member will monitor the questions, and I'll read some of them later in the question and answer period at the end of the conference. And we are recording this presentation and we'll later post it on our website so that you and others can watch it again. Next slide, please. At the LLSC, our mission is to cure blood cancers and improve the quality of life of those touched by a blood cancer and their personal support network. We offer support to those affected throughout their blood cancer experience, so please do not hesitate to contact your community services lead in the area that you live to learn more about what we can do to help you. Next slide, please. As you have surely heard, we launched our brand new website, bloodcancers.ca, in November 2021. Our goal is to better serve the community and to offer an improved experience. On our website, you will find all of our past webcasts, some podcasts, our information sheets, and practical tools to help you navigate your cancer experience and much more. Please visit www.bloodcancers.ca. Next slide, please. Sometimes you may feel completely alone and even misunderstood by your family and friends. When this happens, it can be unsettling and isolating. For those days when it seems like the people who care about you and love you just don't get it, we can help connect you with someone who's been there, someone who's been through a similar cancer diagnosis experience. Our First Connection Peer Support Program is a program where trained volunteers provide information and an empathetic ear to support over the phone by sharing their individual experience. This program is available for people newly diagnosed, in treatment, or even in life after cancer, as well as caregivers. Wherever possible, participants and volunteers are matched based on age, gender, and diagnosis. Please fill out our request form on www.bloodcancers.ca or connect with your community services lead for information. Next slide, please. On our new website, you can also find a multitude of animated education videos. The topics vary from information about specific types of blood cancer to tests and treatments. We are also excited to launch a series of animated videos on topics related to post-cancer and chronic cancers. You can view the first two, Living with Chronic Cancer and Fear of Recurrence, which are now posted on our website. Next slide, please. It is now time to begin today's presentation, Managing Fear of Recurrence. Next slide, please. It is my pleasure to introduce our speaker today, Dr. Christian Schulz-Quach. I hope I'm saying that right. Dr. Schulz-Quach is an assistant professor and clinical educator in the Department of Psychiatry at the University of Toronto and is a staff psychiatrist at the University Health Network Princess Margaret Cancer Centre, Department of Supportive Care, Division of Psychosocial Oncology. Thank you, Dr. Schulz-Quach, for being here with us today. Take it away.
Leslie Ann, thank you so much. It's wonderful to be back again and to be invited back again to all of you out there across Canada. It's a great pleasure speaking to you today, although I would, of course, prefer to speak to you in person and to also have the haptical and olfactory and all the senses feelings that we're all yearning so much for after this very, very long COVID pandemic that is potentially, hopefully, slowly dying down. Thank you for being here for my talk for the next 60 minutes. We will have, well, a little bit less than that, and we will be talking about fear of cancer recurrence. I will start talking a little bit about distress in general in cancer psychiatry, and then we'll talk to you specifically about fear of cancer recurrence and the approaches to it. So in preparation for this talk, I first thought, well, what am I going to do by way of making this very palpable and practical? The first thing I want to say that's really important for us in cancer psychiatry and in psychosocial oncology and psychotherapy in the field of cancer care is that we really understand that there is a common pathway for all forms of mental health distress related to cancer care, which we would call distress. And we should be screening for this type of reaction of emotional disturbance and distress, just as we are screening for temperature, blood pressure, and other vital signs. This is also important because not every distressed person immediately needs a psychiatrist. We don't want to pathologize, and we do not want, in any case, to make people feel like mental health professionals are the only people who can help in a situation of cancer care treatment. But sometimes it is necessary. And so it is also true for the fear of cancer recurrence. As already stated by Leslie Ann, fear of cancer recurrence is per se a very normative and very understandable reaction to a significant life stressor. But it can become more than that, and it can be overpowering and overwhelming in the day-to-day life to a point where functioning is impaired and the individual person feels that their quality of life is no longer sustainable. That's why we typically in the care of distress say that a majority of patients will not need specialist care, but a minority of 10 to 15% of patients in cancer care will require specialist complex care and service referrals. What is this common pathway theory that I'm talking about? Well, when you think about your own cancer experience, the cancer experience of a loved one, if you are a caregiver, or maybe the cancer experience of someone who was otherwise part of your chosen family, then you will notice, or maybe also from other mental health experiences in your life, that there are two main components that really come together, especially in the fear of cancer recurrence. There is the positive motivational network, which basically is everything related to wanting to be active, wanting to go out, to be task oriented, to go forward, to be motivated, which typically is impaired by the sheer impact of the diagnosis, our treatment options that we have available, and sometimes also the sequelae of treatment, such as cancer fatigue, brain fog, etc. The other element that plays a role in explaining mental health issues in cancer care is the stress response network. And the stress response network is basically what we all need so that we don't get overrun in traffic on a daily basis. We need to be aware. We have a part in our brain, the amygdala, that warns us if danger is acute and immediately present. In some cancer survivors, and in particular in patients with a leukemia history, this stress response network is often overregulated, and patients have a high sensitivity to any form of stress, and the amygdala in their brain is firing much quicker and at a much higher frequency than it would in someone who hasn't undergone the same diagnosis and treatment plan. And so how to bring this level of distress, this level of stress response down to a level where it is regulated within normal regions is one of the approaches of treating for distress and fear of cancer recurrence. Before I become specific, I would like to just go back to something I had introduced in November last year already, the different forms of anxiety that we can encounter in cancer. First of all, there is situational anxiety. When I speak to a patient who's referred to me, or a patient who self-referred and wanted to speak to me, I often let them talk about their own experience first, and I want to understand how they contextualize what's going on, what's happening with them. Situational anxiety is what everyone here in this conversation will have experienced before. A stressful life event creates significant levels of anxiety or drop in mood. There might be complications in the family setting, in a psychosocial setting. All of those are not pathological reactions. They are completely normal reactions in our lives. Psychiatric anxiety, as the opposite, is what we would be defining as mental health disorders. So distinct, specifically defined circumstances of symptoms, which would conclusively be put together into diagnostic categories within the DSM-5, which is the Diagnostic and Statistical Manual for Mental Health in Northern America. In the rest of the world, we typically use ICD-10 or 11. That's the newest version. That's the International Classification of Disease, which is a little bit all-encompassing, larger. It comprises all diagnoses within healthcare and not just mental health. That's just a side note. So psychiatric anxiety would be specific phobias, specific panic attacks related to your cancer treatment, a generalized anxiety disorder of diffuse, permanent threat in the background, which you just cannot get rid of. OCD, obsessive compulsive disorder, which we know can develop as a reaction to having felt overwhelmed before, having felt completely out of control and in loss of control, and as a reaction formation to this, obsessive compulsive symptoms can appear, and we will talk about this a little bit more also in the context of fear of cancer recurrence later on. And then, of course, and unfortunately, PTSD, post-traumatic stress disorder, which unfortunately in leukemia diagnoses is not a rare occurrence. And the background to this is, for those of you who have gone through cancer treatment or who have accompanied a loved one. The background to this is that very often in leukemia diagnosis, you have a patient who has a very long period of undetected disease, and then at a trigger point, platelets are so low or hemoglobin is so low that all of a sudden someone notices that there needs to be an investigation. And the moment the investigation has been done, everything changes from basically 1 hour to the next. It's like someone pulling the carpet under your feet. And within 12 hours or sometimes quicker, you end up sitting in a hospital bed surrounded by people who want all sorts of things from you. And within 24 hours, you start a treatment because it's aggressively needed. That is often the story of people who have acute leukemic transformations. And unfortunately and understandably, this can very often be so overwhelming to the system and experience of patients that post-traumatic stress disorder symptoms can follow on. As a psychiatrist and also working in the hospital setting, in the inpatient setting, and as a consultation liaison psychiatrist, I also want to speak about organic anxiety, because not every anxiety and sense of anxiousness is automatically psychological. There are very clear, defined reasons for why a patient can be utterly anxious, distressed, and even psychotic or delirious, based on what we as doctors, as healthcare providers, are actually doing to the patient, or what the treatment option that we have available is causing within the brain or other organs. A typical situation that most of you will know about is when we provide steroids, such as dexamethasone, often used in the context of chemotherapy regimes. We know that steroids can significantly increase anxiety and can actually even go so far that they can potentially create hypomanic or manic states in patients. The last category is the existential anxiety category, and this relates more to the fact that a significant stressful life event like a cancer diagnosis also opens up an awareness about the finitude of life. And it opens up an awareness about the fact that my very own specific life, my individuality, is threatened, which is an experience that not everyone shares if they haven't experienced a traumatic event before in their life. Now, this was a more general introduction, and I want to talk a little bit about specific anxieties in cancer. And of course, today's main topic is the fear of recurrence, FOR, or how it is often referred to now in modern literature is the fear of cancer recurrence. To be very specific, what the recurrence fear is actually targeted towards, what the intentionality of it is. What am I thinking about? This is actually the most common form of cancer-related anxiety post-treatment, often when the treatment has finished. Another word that has been coined and can be found in the literature is scanxiety. So the anxiety of the next follow-up scan, the next regular follow-up scan, sometimes significant distress about having to go back to hospital, which would point towards potential dissociative or traumatic symptoms. And then also the idea of survivor's guilt, which unfortunately in leukemia and lymphoma care is not uncommon, because not everyone can be saved and not everyone is successful in their treatment. And because the treatment is often a long-term treatment, a longer treatment, one makes connections. One starts finding friends, peers, colleagues, and not everyone survives. That leads me to being an existential psychiatrist as I am. The fact that not everything can be explained in words or through cleverness, or me even sitting here as a psychiatrist explaining the world to you. No one can know how you actually feel as you. as the person who's going through this cancer diagnosis, this cancer treatment, who has maybe for a long time now been cancer-free, considered a cancer survivor, but what the very experience of your own uniqueness is with relating to this life event is something that I cannot really grasp in words alone. And so existential theory is a way of thinking about the human experience of being thrown into the world, which goes beyond words alone. One of the proponents of this theory or this theoretic construct is Karl Jaspers, who very much talks about limit situations as those situations in which we have a choice between utter despair or realizing what within all the despair we experience is still making meaning and showing itself to us as meaning-making structure. Another more recent construct is the double awareness construct, which I think is extremely important for the fear of cancer recurrence. It is the balance between life orientation and death awareness when being treated for cancer. Any cancer treatment, when first diagnosed, will evoke a sense of contemplating death and death-related thoughts in patients. We know this for a fact from many studies. It is the balancing between this death awareness and, on the other hand, a strong focus and motivation to keep life orientation, which often helps patients who do not need to see a psychiatrist and those who unfortunately can't find that balance and need extra support to get it, to find that balance in their own thinking and experiencing of life. I'm going to talk about symbolic immortality and Robert J. Lifton a little bit later. I just want to maybe point out at this point that for patients, and especially young patients with leukemia diagnoses who have not yet constructed a cohesive sense of self, a cohesive sense of this is me, basically who do not have an answer to the question of who am I. For those patients, there is often a very high risk of developing existential anxiety, existential distress, which then is a form of distress which has to do with a deep, deep worry and fear of existence annihilation. Now, fear of cancer recurrence. Why are we talking about this at all? I have data from 2018 with the most recent data I could find in preparing this talk. And this paper reported that in 2018, around 44 million people around the globe were cancer survivors which had been diagnosed within the last 5 years. We know that a very large amount of people is struggling with the fear of cancer recurrence after treatment. And so we're really talking, when we're talking about this phenomenon and about this symptom, about a really, really large group of patients. The fear of cancer recurrence is, as the literature tells us, the number one unmet need in cancer survivors. And it is defined as the fear, worry, or concern relating to the possibility, not the knowing, not the convinced, but the possibility that cancer will come back or progress. There's also an attempt of operationalizing what that actually means. And I want to put a few bullet points out here, which are the outcome of a Delphi study of experts, where they all were put together in a virtual room and had to discuss about, what are actually the elements of fear of cancer recurrence. And those are the ones that they came up with. It's a high level of preoccupation with the thought of cancer recurrence. Just because someone rationally and objectively states, well, I am aware that my cancer has a 5%, 10%, 50% of likelihood or probability of recurrence doesn't mean that they have a fear of cancer recurrence, but rather it's a preoccupation, a constant and permanent preoccupation with the topic. High levels of worry are very important to mention as well, because this is part of the anxiety construct, the fear construct, and it is very important that fear of cancer recurrence as a syndrome, because it's not really a diagnosis, it hasn't found its way into the DSM-5 or the ICD-11. It's a more syndromal description of experiences of cancer patients. It needs to be persistent over time. It is not an experience that blips up and then leaves. As a matter of fact, we do know, I'm jumping to point 5, that fear of cancer recurrence typically does not decrease over time without intervention in those who are really suffering from a significant level of fear of cancer recurrence. And then another element is the fourth point, which is part of the construct description, and that is a sense of hypervigilance to bodily symptoms. And I will go to a few questions that some of you have posted earlier that you would like me to address in this talk, and I will. Those are questions relating to, I have had treatment and now every little pain that I feel, I immediately in my mind go to, this is a recurrence, this is it, this is the recurrence. So this hypervigilance would actually speak to something that in trauma-informed care would be part of an understanding of being traumatized and having a very, very highly dysregulated stress response system, as I talked about earlier. The fear of cancer recurrence inventory is a measure which I just want to introduce here, because I am very confident that most of you are searching the literature and looking up literature, and you might have come across it, so I want to mention it here. It's by now the most established measure that's being used to compare different cohorts of patients in different countries across continents, and it's a 42 items questionnaire to find out more about the fear of cancer recurrence. It has a 7-factor structure which relates to the factors that are listed here. And I just want to mention it again so that I have a concrete specific statistic that I can share with you. It's a very recent systematic review, which is a literature overview of every research data that's available to a specific topic. And there's a very recent systematic review which found that the prevalence of fear of cancer recurrence is in those 10,000 respondents, close to 10,000 respondents that were involved in this systematic review, is around 58%, in such a way that the cutoff within the FCRI for defining an experience as fear of cancer recurrence is typically at 13 points. So if a patient has more than 13 points on this scale, then they are considered to have a fear of cancer recurrence. That's a very large number. That's more than half of all patients who are cancer survivors. I would be very interested to hear what your experience is, and maybe also encourage you to share in the chat whether you yourself experience fear of cancer recurrence as well. If you don't want to, if you don't feel comfortable, please absolutely just listen to me. But it would be important to me to hear whether I'm speaking to something that people in the audience can relate to through their own experience or the experience with others that are close to them. Now I want to show this one slide to you because I found it really, really important in my own grappling with fear of cancer recurrence. I'll be very open. As a European psychiatrist, I'm a little bit stereotyped towards Northern American new constructs in psychiatry, where people for several reasons find that they have found a new name for a syndrome or a symptom, and now they're trying to establish this under their own name or their own organization. And so when fear of cancer recurrence first came up, I will be very honest, as a psychotherapist, I thought, well, that's existential distress. That's an anxiety symptom. It's basically already explained by the diagnoses we have. It turns out that actually the fear of cancer recurrence is very separate and very different from typical anxiety and depression diagnoses. And this very interesting study here, and typically, by the way, and I see in this slide I omitted it, for every slide that follows now, when I have a study I'm referring to, I have a QR code in the upper right corner. And if you want to use your phone and hold it against the screen and scan the QR code, it will directly take you to the study that I am talking about. So I want you to just look at this slide, and what they did is a so-called network analysis. They used the three most common instruments in testing for the prevalence of symptoms. The PHQ-9 is a standard measure which you will surely have come across in your own hospital visits, which is a depression screening instrument which is used worldwide. And thank you all for sharing in the chat your own experiences. I am reading them along while I'm talking. And the GAD-7 is a standard measure internationally used for anxiety symptoms. The FCR is a short version of a 4 items measure for fear of cancer recurrence. And what you see here is that all the bobs and circles are connected with each other. The stronger the connection, the stronger the color and the thickness of the line, the more different items on a scale are correlated to each other. The most important element you can see here on this screen is that the 4 items of fear of cancer recurrence actually are pretty separate from everything that's happening here. The anxiety and depression items that are asked of patients. There's 2 tiny lines here that are connecting to a PHQ-6 item and another item on the anxiety scale. But overall, and this is the point I'm trying to make, and it was my learning as well 15 years ago when this construct was more and more introduced into our community of professionals, it is actually evident that the fear of cancer recurrence is distinctly different and very significantly different in its phenomenology, how it presents in patients who might very well say, I don't have a general anxiety problem. I don't feel depressed, and I don't have depression. But I do have this very, very distinct fear of cancer recurrence, which really, really is weighing me down a lot. Another study that I am presenting today is giving evidence specifically for leukemia and lymphoma patients that over 50% of patients with chronic hematological cancers actually show clinically significant signs of cancer recurrence. Although at the same time, in the same population in this study, 70% of these patients actually had, as per their expert oncologists treating them, a very low risk of recurrence. I'm making this point specifically to make it clear that there is a difference between the objective finding of recurrence probability and the perceived psychological distress and threat coming from thinking about cancer recurrence. And again, just driving this point home here, that fear of cancer recurrence typically remains stable over time. It is not an attenuating adjustment disorder reaction, which we might be finding in patients who have gone through a very difficult phase in their life or have had a psychosocial stressor and after 3 to 6 months actually go back to baseline. Fear of cancer recurrence is very persistent and pervasive. So here on the right hand side you will find questions that were asked prior to today's session, and one person had written, I have been in remission for 6 years and I have multiple myeloma. What strategies can I use to prepare myself for a recurrence? I'll talk to this a little bit more in a second, but I just want to say that first and foremost, there is a difference between having a fear of recurrence because of the objective, clear fact that recurrence is almost unavoidable, or someone who is having a fear of cancer recurrence, although they are considered for 20 years now cancer survivors. I want to speak a little bit more also to the relationship between fear of cancer recurrent and existential distress. I had alluded to it a little bit earlier in a slide about existential theory. Fear of death, as opposed to fear of cancer recurrence, is a very normal, innate instinct that often is activated by becoming aware of my own death. A fear of death actually is quite important for us to even do anything in life. Because if we had no fear of death and we felt like we would live unlimited time in the world, why would we make any choices at all? Because we can do everything whenever. There's also a sense of that an absence of death awareness and an absence of thinking about death as an idea, not necessarily as an ultimate threat and ultimate truth in the near future, but rather as a concept, is actually quite helpful so as to not fall into an autopilot in which one gets a false sense of certainty and a sense of lack of ownership over one's life because everything is just floating along and I don't feel that I really am aware of my existence. So fear of death or death awareness is per se not a negative thing. It can become overwhelming if it becomes so pervasive that I can no longer think about the life orientation in the double awareness of things at the same time. And that is what double awareness is about. When thinking about death and death awareness, there are a number of threats that often come to mind and patients talk about. It's a sense of loss of control of oneself. Often it is not about oneself, but about others that are meaningful and important, speaking to attachment theory and the relational aspect of what it means to be you, what it means to be your identity and your family, your friends, your chosen family, or just those who are really meaningful to you. The two strongest predictor of elevated death anxiety in hematological patients are a sense of purpose in life that's lacking. I don't know why I'm alive in the first place. And fear of recurrence. So there is a strong connection between persistent death awareness, not just at the moment of diagnosis, not while I'm adjusting to something that's threatening me, but as a persistent sense of awareness, and the fear of cancer recurrence. Someone asked, how can a relative help someone move past an irrational thought? I assume X means that this is referring to an ex-partner. I'm not going to live past 70s as neither of my parents did. So that's a little bit interesting. I, for example, as a psychiatrist, wouldn't label this as an irrational thought. I would say, okay, that makes a lot of sense. You have the experience, the life experience, that those who were most important to you and who also were those who were supposed to support you and protect you died early. So I think the thought per se is not irrational. As a matter of fact, I think it's a very important thought to have. It is probably more about how we discuss about this thought and how we make sense of it, why it seems so hopeless and nihilistic, that there is no chance and possibility for me to survive beyond what others have lived, that makes the difference between a thought becoming obsessional or just an indication for the fact that I haven't found the right angle of addressing it from an existential psychotherapy point of view. I'm going to pause quickly. I just want to take a quick look here at the chat. Okay, X is example. Thank you very much that I didn't pick up on this. This is my unconscious bias. Thank you. Very interesting question here. Why does it have to be called a disorder and pathologized when the majority of people experience it? Why add the stigma of a mental health diagnosis? So, if this refers to fear of cancer recurrence, then I just want to, Nishama, thank you very much for raising this very important question. I just want to point out to you that we are not calling it a diagnosis, and that no one has an intention to call it a diagnosis. It is, as a matter of fact, as I said before, a more syndromal description of something which has very clear and distinct impact on quality of life and on the functioning, the daily functioning of people who are overwhelmed by fear of cancer recurrence. So maybe it is a bit of an attempt to find an intervention that can help to solve the problem rather than trying to create pathology. I will, however, agree that it is important to keep that in mind and not to turn fear of cancer recurrence into a diagnosis just because we are trying to find a solution for it. So thank you very much for raising this point. I see a lot of people sharing with us here that they do indeed experience significant fear of recurrence. Michael shares that there's a reality that AML could return, and he's currently healthy, which is wonderful to hear. And he's trying to find that balance, which would exactly, from a psychotherapy point of view, speak to double awareness, the need to think about both at the same time, to think about life orientation and how can I stabilize my sense of quality of life, how can I stabilize my quality of life, but at the same time, how can I also create a space in which I can talk about my more existential and difficult thoughts in a way that is tolerable for those around me and for myself. Okay, I'm going to go on here at this point. I will listen to more later on. And please, if someone feels like I have not yet responded to their chat message, then Leslie Ann will point me towards it in about 10-15 minutes. So there were two questions which I found very, very helpful before starting this talk, where two of you reached out and said, do you agree with the concept that with a positive attitude one can control the recurrence of your cancer, and why? And a similar one was, can stress cause recurrence? So the first thing I want to say is no, I do not believe that. I do not believe that we have the power to control, because that's the word that was used, to control whether a recurrence will occur or not. And as a matter of fact, that is a very important message I want to send, because there is sometimes professionals who do not necessarily directly work in cancer care out there who are trying to help desperate people with everything that they have to offer, who sometimes follow the notion that there is actually nothing more important than having full mental control over yourself, and then recurrence won't happen. I think this can create massive, massive suffering, and I have found in my own practice that some patients have felt extremely depressed and guilty about the fact that their mental health wasn't strong enough to fight against cancer. And so I want to say I do not see, and I don't think that there's any evidence to say that there is an immediate control effect of mental health on a recurrence, yes or no. There are associations, and they make a lot of sense. I've put down some information here on this slide. We do know that anxiety, especially health-related anxiety, can negatively impact quality of life and psychological well-being. That is relatively straightforward. We also know that low quality of life and low psychological well-being is highly associated with depression, despair, and hopelessness. Now, because of those connections, we can also see that on the behavioral level, someone who is more depressed, hopeless, and desperate will negatively be influenced in terms of their screening behavior, their attendance to follow-up appointments, their health behavior in general, such as using substances to stabilize their emotional regulation, etc., or using other maladaptive coping behaviors. So there is indeed a connection between mental health and behavior, but it is the actual behavioral shift that could potentially have an influence on whether recurrence happens or not. But that would be because of not following through with recommendations or simply not having the motivation, going back to the common pathway model, not having the motivation to really see through all the recommended follow-ups, or just disengaging from healthcare services altogether. So in that sense, in the sense of the impact of mental health on behavior and mental health on health outcomes in cancer care, there is a connection to life expectancy, but it is not as straightforward as asked in this question. And I would be very, very careful with making this assumption. It can seriously hurt those who are trying very hard to keep their head over water if they feel like they are responsible for what's happening to them. Especially in leukemia and lymphoma care. A fear of cancer recurrence. Now I wanted to talk a little bit about treatment options. And I would like to just point you towards two very, very fascinating publications. The QR codes are here in the upper right end. So let's take head on the challenges over the last 3 years. Especially for patients who have chronic illness and patients who need long-term treatment. The cancer treatment shifted massively during COVID-19. Appointments were harder to get when they were available. They were under very specific conditions. They were socially stressful because sometimes those who are caring for us were not allowed to join us, etc., etc. So maintaining social support in general was much more difficult, and continuing cancer treatment and medical checkups became a huge challenge, especially for those who maybe not have a fully intact chosen family system or social system of support, those who were alone in the first place and who felt that they were now no longer able to maintain their healthcare cycle. This was relevant in cancer care, but it was also relevant for the treatment of fear of cancer recurrence, because the original models of supporting patients with fear of cancer recurrence were in-person models of traditional CBT, which could no longer be performed. And there was a massive shift to remote treatments, which were now researched. And the question was, are they effective? And this particular systematic review study actually revealed that they are at least as effective as in-person support, if not even more supportive and effective, because they're available at the fingertip. They're available when you feel like you want to invest into the topic and not when the therapist has a session available. There was one question from among the audience. Our daughter is nearing the end of 2.5 years of treatment for high-risk ALL. She was 5 upon diagnosis. How do we cope with the fear of moving forward? Now, this is a very, very large question, and probably one that I cannot fully answer at this point to completion. But I think we can all relate to the question and understand why it would be asked. when I did a bit of literature research and trying to come close to an answer to that question, I found one study which showed significant elevation of fear of cancer recurrence in childhood cancer survivors, and that this significant increase is directly linked to increased outpatient and emergency visits after survivorship, in the survivorship interval. But the interesting piece was that it was not based on the children's fear of cancer recurrence, but on the parents' fear of cancer recurrence. So when you ask, how do we cope with the fear of moving forward, I think even asking that question in the first place is already a huge step, recognizing that there might be a difference between the fear that your child experiences and the fear that you experience. Maybe a difference between how you can articulate your fear and how your child cannot articulate it as yet, or how traumatized your child is from everything they might have gone through. I highly recommend to connect with a child psychotherapist or a family therapist to discuss these topics separate and together, and to cultivate a atmosphere in your family, which I'm sure already exists, you wouldn't have asked the question otherwise, in which you can openly keep discussing the emotional reactions and the emotional processing of what you all have gone through over the past 2.5 years, because you have experienced it as a family system. And that is also true for everyone who is on this call, who is a cancer caregiver, who is a caregiver to a cancer patient, who is a family member of someone who is a cancer survivor. All of you are experiencing this together, and sometimes caregivers can have a much higher sense of loss of meaning and a much higher sense of mental health burden than patients themselves, because we unfortunately are not very good yet in recognizing the needs of healthcare providing caregivers within the cancer care treatment spectrum. So how now can we treat fear of cancer recurrence? Psychological interventions that we are offering are typically based on CBT, cognitive behavioral therapy. Why is that so? Well, because the construct of a fear of cancer recurrence is a very cognitive, it's a very thought-related construct. It's not so much about the primary physicality of experience, but it's about this thinking, this going back, ruminating about a thought of recurrence. Traditional CBT has been shown to be effective. Contemporary CBT has been even more effective. There is a study which shows that mindfulness, acceptance, and commitment therapy are superior to traditional CBT, hot cross-bun, and anxiety escalation, etc. So mindfulness, acceptance, and commitment therapy seems to be more effective. There are also studies that show that emotion-focused psychotherapy, which focuses more on an insight-oriented understanding of what emotions I'm feeling with regards to the fear of cancer recurrence. There's fear, there's anxiety, but maybe there's more. Maybe there are other emotions as well. Guilt, anger, frustration, shame, love, and so on. And then there are also recent studies which show that group settings and group psychotherapy, online and in person, are effective in treating, and now I'm going to be very specific again, treating these symptoms and not a diagnosis. Because fear of cancer recurrence is not a diagnosis, it is a syndrome, it's a symptom. I want to finish by saying something that's important to me. I have spoken about it throughout the talk. Fear of cancer recurrence might be what you think you have, and it might be what you might be coming to your oncologist or after referral to your psychotherapist or psychiatrist with. But it might also be the case what you're really experiencing is post-traumatic stress after very, very invasive, transgressive treatment. PTSD is a very significant quality of life impairing diagnosis. Now we're talking about diagnosis. Here we are in a situation where avoidance of stimuli, where hypervigilance, permanent hypervigilance, and complete being overwhelmed and dissociated in certain circumstances leads to diagnosing this mental health diagnosis. And it needs a very specific, different approach. CBT alone is not effective in treating post-traumatic stress disorder. So if you are in doubt and you don't really know whether what you're experiencing is fear of cancer recurrence, but rather maybe a post-traumatic stress disorder, then please reach out to your oncologist and let yourself be referred to a psychosocial oncology service or a psychiatry service to have a conversation and assessment about these topics. There is, of course, also post-traumatic growth, and fear of cancer recurrence can be part of it. I can have fear of my cancer returning, and I can own it, and I can be aware of it, acknowledge it, and say, this is part of me. I am fearful of getting a recurrence. I haven't had it so far, and I'm going to focus on both. My fear that it might happen, and I will prepare for it, but also the life I'm living right now, the life I have after my cancer treatment as a survivor. Often, patients who undergo significant cancer treatment have increased psychological mindedness. They are more aware of what their emotional disposition is, what is good for them and what is not, which people around them are good to them, feel right or don't feel right. And there's often also a sense of understanding better what the deeper sense of meaning and meaning purpose in life is. I'll keep it at this. This was an overview over a number of mental health topics. I hope that you have some questions, which I will try to answer at the best of my capacity and knowledge. And please do also reach out to me via my email address, which is basically my name, christian.schulz-quach@uhn.ca. Thank you for listening to me, and over to you, Leslie Ann.
So thank you for sharing your expertise and insight with us today. It's time now for our question and answer period. If you haven't done so already, please put your questions into the Q&A box. It's a little bit easier for us to keep track of, but I have taken some of the questions out of the chat. And so right now I can see 3 questions. So the first one, Christian, is, are there ways to reverse or stop OCD tendencies? I've heard that it can be really hard to treat even with therapy.
Okay, so you're speaking to a very, very interesting topic. I actually have worked in the National Specialist Centre for OCD in the UK before I came over here to Toronto, and so can really speak to this topic. Because there is an overlap, and some people say it is very important to assess when someone comes with a fear of cancer recurrence, whether what they're actually experiencing is obsessional type OCD, obsessive compulsive disorder. It can relatively quickly be differentiated, and OCD treatment nowadays is very clear cut. OCD is best treated with a combination of specific medication, which is effective, but only in the combination with a specific OCD CBT, which is called exposure response prevention, ERP. This type of treatment is basically a treatment where you develop together with your therapist, first of all, rapport. Then you sit down and you create a list of items that are giving you your OCD triggers that make you really become very obsessional about a certain topic, and then making you to compulsively act out to contain those trigger anxieties. And then you create a hierarchy, a priority list of which trigger is the worst and which trigger is the least uncomfortable. And then you start working from the bottom to the top with your therapist in vivo, in real life, through those triggers, and you're trying together with your therapist to stay with the anxiety, which is different from fear of cancer recurrence. In fear of cancer recurrence, you would not get better by staying in your anxiety, but rather it would be potentially detrimental to you. In OCD, you will realize that actually the anxiety trigger you have in your mind is not all that overwhelming. And with exposure response prevention therapy, you have a very high chance, together with medication support, to actually overcome OCD. I want to say one thing though, very quickly. OCD in the specific context of cancer treatment. Let's say I have a 68-year-old patient who has a leukemia diagnosis, is considered a survivor, and comes to me and says, I have newly developed OCD. I will, of course, still offer them the treatment for OCD, but I will formulate it differently. I will first and foremost see the OCD symptoms as a solution to an underlying, more existential, threatening problem. And I will not just jump onto making those OCD symptoms go away, but rather I will discuss with the patient whether they are, in a trauma-informed way, ready and willing to let go of the OCD symptoms to maybe uncover what's underneath.
Sorry. My next question that came up was, and I think you sort of touched on this in your last slide with the post-traumatic growth, but does fear of cancer recurrence motivate positive health behavior choices? And does it lead to a high level of stress when you're not able to choose the positive health behaviors?
I need to have help me ask this question again. I don't think I picked up the question properly.
So I think what they're asking was, does somebody who lives with a fear of cancer reoccurrence want to be a positive in their health choices? So does being scared that your cancer is going to come back make you want to exercise more, eat better, to avoid those negative things that might cause it to come back?
Okay, understood. So two things I want to mention. First of all, each of us, when we were diagnosed with any form of health condition, will, if we're healthy, have a reaction to it that will be positive coping oriented. We'll try to make it better. We'll try to somehow get away. And we will maybe also bargain and say, okay, so if I continue to really eat very healthy going forward and exercise, etc., am I going to be spared? That's a completely normative reaction, and that's great. As a matter of fact, that's what we call rehabilitation. So that's good. But at the same time, if now these health behaviors become excessive, I am running excessively and I start, for example, to cancel on my friends because I have to run, because the running is the only thing I feel I can do to control my anxiety about my fear of cancer recurrence. That is where a positive health choice can all of a sudden switch into becoming a destructive behavior. That's one way of answering the question. The other way of answering the question is, do I have someone who knows that it would be the right thing for them to change their health habits, changing their nutrition, changing their exercises, but they do not have the motivation? They just can't. Cognitively, they're aware. They understand it, but it's just not happening. They can't translate it into real life behavior. Then I will have to go down the route of thinking, okay, is there maybe a depressive disorder? Is there an anxiety disorder? As I said, there is a significant difference between fear of cancer recurrence, but it doesn't mean that I can't have both at the same time. And that would, as a psychiatrist, make me wonder, is there maybe a depressive disposition in this patient that I need to address as well? So that's my answer to the question.
Okay, so I think we have 3 more questions and then we'll need to wrap it up. And if any questions are not answered live, one of the CSLs will reach out to you and try and get some answers for you. So, excuse me, the first question is, when we talk about the fear of cancer recurrence, does that also equate to metastasis, or is it just a fear of recurring of the same cancer?
No, it also speaks to any form of progression. I would say recurrence and progression, and therefore also metastases. And I
Okay.
want to say it again. Having a fear of a metastasis, or metastases showing up, of recurrence or progression, is normal. I would have that very same fear. The question is this experience leading me to a functional impairment where my day-to-day life is impaired and disrupted, and I'm no longer talking to my family member, to my husband, to my spouse, because I'm so preoccupied with being worried about this topic?
Okay. So the next question is, there are numerous studies that seem to say that our lifestyle choices cause cancer. Some people seem to think that we caused our cancer, or something that we did caused our cancer. This leads to guilt. How do you handle this? And how do you handle these studies? And how do you talk to your friends who feel this way?
Now, this is an utterly broad question, and I really would have to speak a whole day about this. I would ask the person who asked the question to kindly please reach out to me. I'm very happy to
Okay.
have an email correspondence about this. Very short answer is there are cancer spectrum diagnoses where there is a direct association. If someone who has a stage 4 non-small cell lung cancer, who has been smoking for 60 years, doesn't want to talk about this association, then as a psychiatrist, I would say that's a problem. However, we have many, many other conditions, and specifically leukemia and lymphoma conditions, where we have no clear clue of why this particular person or this particular family system is experiencing these diagnoses. So I personally am extremely reserved when it comes to pointing fingers or evoking shame or guilt. I think these are very, very powerful emotions, and they can cause massive suffering.
So I'm just going to ask one more question and then we'll start wrapping up. So with regard to managing fear of reoccurrence, the self-talk that you mentioned at the end, for example, saying it hasn't happened yet, I'm okay. How do you change that, and help your mind change if you have had a relapse and you're afraid of another relapse?
Well, it's becoming significantly more difficult, right? This is a very good question. How can I even get to the point of having a sense of safety again when my safety now for the second time has already been taken away from me in a situation where I felt out of control? Didn't expect it, maybe. So it's harder. And I can't give you the magic answer right now. What I can say is it's really, really important to keep talking about it, to find people you can talk to about this. And very often in a situation like this, I would personally recommend an online support group once a week with people who have similar situations, maybe facilitated, in which you can just confirm to yourself that what you're thinking is not wrong, it's not pathological, but is what many other people would be thinking in that very same situation as well. Again, fear of cancer recurrence is not a diagnosis. It's a syndrome, and it can hurt people a lot.
Thank you very much for answering those questions. Next slide, please. So before we sign off today, I'd like to mention that we have 3 more presentations being offered this week in the Your Life After Cancer conference series. June 15th, we have at 12:15 p.m. Surviving and Thriving with and Beyond Cancer, a guide to rebuilding your life. And at 4 p.m. Cancer and Work, tools and resources to help you to help and support you. And then on the 16th at 12 p.m., Living Well and Beyond Cancer, the vital role of physical activity. Please visit our events page at www.bloodcancers.ca to register for any and all if you have not. Just a reminder, all times are Eastern times. Next slide. So we would like to thank Kite, a Gilead company, and Pfizer for making the Your Life After Cancer conference possible. And next slide. Finally, please remember that we are always here to help you. We're here for you every step of the way. You can reach out to us by email, by visiting our website, or by calling toll-free. Please note that a brief survey will be sent to all participants after this presentation. Please take a moment to respond to help us plan beneficial events to you soon. Thank you for being with us, and please take care and stay safe.